Ischemic cardiomyopathy occurs when reduced blood flow from coronary artery disease weakens the heart's function, often reflected by a left ventricular ejection fraction of 35% or less. For years, clinicians have debated whether adding coronary artery bypass grafting, or SABG, to optimal medical therapy, known as OMT, can improve survival for these patients. The STICH trial holds particular significance. While earlier studies, such as the CASH trial, hinted at potential benefits of CABG in certain subgroups, the STICH trial was the first large randomized study specifically designed to examine this question in patients with severe left ventricular dysfunction and stable coronary artery disease. Let's delve deeper into this clinical question. Does optimal medical therapy, or OMT, combined with coronary artery bypass grafting improve mortality in patients with ischemic cardiomyopathy and a left ventricular ejection fraction of 35% or less compared to OMT alone? Let's dive into the findings. The bottom line is this. In the short term, adding coronary artery bypass grafting to OMT reduces cardiovascular-related deaths and hospitalizations, but does not significantly reduce all-cause mortality after 5 years. However, at 10 years, coronary artery bypass grafting does show a significant reduction in all-cause mortality compared to OMT alone. Major points 1/3. Let's start with some historical context. The CASH trial in 1985 found no overall survival benefit of coronary artery bypass grafting compared to OMT in patients with stable coronary artery disease. However, coronary artery bypass grafting was beneficial for a subset of patients with systolic dysfunction and 3-vessel disease. This left a gap in evidence about the best treatment for patients with severe left ventricular dysfunction, particularly those with an ejection fraction of 35% or less. Major points 2/3. The STICH trial, launched in 2009, explored this gap. Over 1,200 patients with stable coronary artery disease and LVEF of 35% or less were randomized to receive coronary artery bypass grafting plus OMT or OMT alone. At a 4.7-year follow-up, there was no significant difference in all-cause mortality between the two groups. However, coronary artery bypass grafting did lead to fewer cardiovascular-related deaths and hospitalizations. Major points 3/3. Now let's fast forward to 2016. At the 10-year follow-up, coronary artery bypass grafting demonstrated a significant reduction in all-cause mortality, with rates of 58.9% in the coronary artery bypass grafting group versus 66.1% in the OMT group. Additionally, a second hypothesis in the STICH trial evaluated whether adding surgical ventricular reconstruction to coronary artery bypass grafting provided further benefit. Unfortunately, no improvement was observed. Guidelines, AACCF 2013. Here are the AHA and ACCF guidelines from 2013 regarding revascularization. Coronary artery bypass grafting, or PCI, is strongly recommended for patients with heart failure who have suitable coronary anatomy. Coronary artery bypass grafting is reasonable for survival benefit in patients with severe LVEF reduction, particularly with multivessel disease or viable myocardium. Even in cases without viable myocardium, coronary artery bypass grafting may still be considered in patients with operable coronary anatomy. Study design. Let's review the study design. The STICH trial was a multi-center, randomized controlled trial conducted across 99 centers in 22 countries. It enrolled 1,212 patients with ischemic cardiomyopathy from 2002 to 2007 with a mean follow-up of 4.7 years. The primary outcome was all-cause mortality. Study design. The trial randomized patients into 2 arms, coronary artery bypass grafting plus OMT or OMT alone. Most patients in the coronary artery bypass grafting arm underwent surgery within 10 days of randomization. In the OMT arm, 17% of patients eventually crossed over to coronary artery bypass grafting with a median delay of 142 days. Inclusion-exclusion criteria. The trial included patients aged 18 or older with LVEF of 35% or less and coronary artery disease suitable for revascularization. Exclusion criteria included critical left main disease, recent myocardial infarction, and poor medical adherence. Importantly, patients with a life expectancy of less than 3 years or high surgical risk were excluded. Baseline characteristics. Here are some baseline characteristics of the enrolled population. The average age was 60 years, with 88% being male and 66% identifying as white. A significant majority, 77%, had a prior myocardial infarction and 39% had diabetes. In terms of medications, 85% were on beta blockers, 82% on ACE inhibitors, and 81% on statins. Primary outcomes. Looking at the primary outcome of all-cause mortality, there was no significant difference in the intention to treat analysis. Mortality was 36% in the coronary artery bypass grafting group versus 41% in the OMT group. However, per protocol and per treatment analyses did show a statistically significant mortality benefit with coronary artery bypass grafting. Secondary outcomes. The secondary outcomes were also noteworthy. Coronary artery bypass grafting reduced cardiovascular-related deaths, with rates of 28% compared to 33% in the OMT group. It also significantly lowered the risk of hospitalizations for heart failure or cardiovascular events, as well as the composite outcome of all-cause mortality and hospitalizations. Criticisms. Like any trial, STICH had its criticisms. The authors noted that the study lacked the power to detect a mortality benefit early on, and the open-label design may have influenced non-fatal outcomes. Additionally, there was significant crossover, making it harder to interpret the intention to treat analysis. Criticisms. External feedback highlighted other issues. Enrollment was slow, raising concerns about generalizability. The study population was younger than those typically undergoing coronary artery bypass grafting, and ICD usage was below current guideline recommendations. A larger trial with at least 1,300 participants in each group was suggested for more robust results. Conclusion. In conclusion, coronary artery bypass grafting added to OMT provides meaningful benefits for patients with ischemic cardiomyopathy and severe LV dysfunction. In the short term, it reduces cardiovascular-related deaths and hospitalizations, and over the long term, it significantly reduces all-cause mortality. Further studies could strengthen these findings and address the trial's limitations. Thank you for your attention.